I was fascinated with the intersection of the financial components and the ability and the opportunity to help people access care. That was really compelling to me. Very early in my career, when I saw the ability that insurers have to help their members and patients navigate the healthcare system. The healthcare system is way too complex. And the concept of care coordination, case management, I was really struck by that.
And now, from San Francisco and the UCSF Rosenman Institute, the Health Technology Podcast with your host, Christine Winoto.
Our guest today is Drew Hobby, the Executive Vice President and Chief Revenue Officer of Blue Cross of Idaho. Drew has spearheaded the transition from fee-for-service to value-based payment, making healthcare more affordable for members and clients. And he now oversees the healthcare economics, IT, and strategy teams pushing for innovation in healthcare delivery and affordability. Drew's deep understanding of healthcare dynamics and commitment to value-based care emphasizes the significance of innovative strategies in enhancing patient outcomes and controlling costs. His work has not only transformed healthcare economics at Blue Cross of Idaho, but also improved access to care for many underserved populations. In this episode, you will hear about Drew's insight on the complexities of health insurance, the importance of proactive care management, and his efforts to tackle the healthcare affordability crisis. Here's our conversation. Welcome, Drew. Thanks for joining me today.
Thank you. Thank you for having me. Good to see you, Christine.
I'm really excited to have you today because I think our listener can learn a lot about your work. I always like to ask our guests the first thing first is oftentimes like, what's the journey, what the path that you took to get to where you are today? Did you always know that you were interested in healthcare from the get-go?
No. I knew I was interested in business. And I think like many people, I grew up, my mom was a school teacher, kindergarten teacher, and my dad worked in the corporate world. He worked for a couple of large corporations. And I think I was always fascinated by his stories and would hear him talk at home about what it was like to be in the business world. And I think like many people, they see their parents, and I love my parents, revered that job and really just said, I'm going to business school. I think, even in high school, I knew I wanted to go into business. Fast forward, I get through business school, and then I started my career with KPMG and their advisory group. Found that I just really enjoyed consulting. I love the opportunity to be a business tourist. I love, early in my career, I had grocery clients and manufacturing, hospitals, all kinds of different industries that I was able to see. And then one of the industries that I had exposure to, it was a company had popped up in Tampa. I was in the Tampa, Florida area, and a company had popped up that was in health insurance, specifically Medicaid and Medicare. And I started working with that company in an advisory capacity. And I found that I really enjoyed what I would call the business of healthcare. Health insurance, I really enjoyed. Medicaid and Medicare, I still have a passion for. I love being able to serve that population. It's very easy to get behind the mission of what you're trying to do from that standpoint. And so, as I was looking to migrate out of consulting into an actual corporate position, I knew I wanted to be in health insurance and healthcare, health insurance specifically. Health insurance, I was very attracted by how complex it is, which sounds strange. And now here I am, 46, and the complexity drives me crazy. But I enjoyed that. I also enjoyed it's always changing. Healthcare is always changing. And I feel like if you can't get comfortable with change, you can't adapt quickly. Healthcare is very difficult to work in, especially in health insurance. And so that's the background. So fast forward, I went to work for a company called WellCare Health Plans, national Medicaid, Medicare plan. And then through some family opportunities, my wife is from Boise, Idaho. We moved to Boise, Idaho, and I began working at Blue Cross of Idaho about 7 years ago. It has been an unbelievable journey. I did not grow up in the Blue system, so the Blue system was a little unique and new to me. But it was very enjoyable to go from a national publicly traded for-profit health plan to a single state independent nonprofit health plan. There are pros and cons to both. But from me and in my career and what I've been able to do here, I've really enjoyed working in that environment. So that's the background.
Yeah. This is the first time I hear somebody mention about consultant as the business tourist. That's really interesting. You mentioned that you're interested in the health insurance, and actually many of, I came from the device world. Oftentimes when people think about health insurance, it's always, it's like, what a pain, right? What are the things that you think that oftentimes is misunderstood by people about health insurance?
No, that's right. You could go to any high school, and if you ask people to go into healthcare, I don't know how many people would raise their hands if they wanted to go into health insurance. I was fascinated with the intersection of the financial components and the ability and the opportunity to help people access care. That was really compelling to me. Very early in my career, when I saw the ability that insurers have to help their members and patients navigate the healthcare system. The healthcare system is way too complex, unbelievably complex. And the concept of care coordination, case management, I was really struck by that. I was really struck by how much of an opportunity there is to be healthcare. Actually, as big as it is, it's really a life on a life. And I love that opportunity. And then I was struck by the fact that an insurer has the opportunity to incentivize, promote, encourage proactive access to care. And when you're talking about really complex conditions, polychronic care, et cetera, I've always seen that encouraging proactive access to care is also 99% of the time the right financial decision, from whether you're a self-funded employer or you're the government or you're a fully insured health plan. An example that would be, I remember talking to some care coordinators, and they were talking about the way that they serve diabetic patients. And they were talking about the lengths that they go to one, try to contact the folks that are diagnosed with diabetes. Everything they do, whether it's schedule appointments, organize transportation, paying for transportation, get that member into with the doctor as much as you possibly can, right? So number one, and most importantly, that's better for that member, that patient, proactively managing their condition. And you can live a very, long and fruitful life with that condition. That is always better for the member and the better financial decision versus not seeing a physician, not taking the medication that you need, an exacerbation of the condition. Next thing you know, that patient shows up in the ER after 6 months of not managing the condition, taking the proper medication, and their legs swollen 3 times of what it could be, right? The costs associated with that, the experience of that member, the lifestyle impacts are way more expensive than the opportunity to call that person on a weekly basis, help them navigate getting their medication, getting doctor's appointments, scheduling transportation and paying for transportation to the doctor. And so I think from a health insurance standpoint, it's still to this day, I love the opportunity to coordinate care and really help people navigate the healthcare system. That's something, when it doesn't go well, that keeps me up at night. When it goes well, that's what makes this all.
Mm-hmm. It's interesting. I mean, when I work at Kaiser, that's when I first found out that Kaiser paid their members to the taxi ride to go see that particular doctor. And somehow, as a regular people user, we don't think about it. We only see the news that health insurance did not do. And I think how helpful it is for innovators to understand that there is different aspect of the health insurance. That oftentimes is, people always say, oh, they don't want to pay for this service. They don't want to pay for that service. They don't want to cover my technology.
Yeah, the other area that I would say, and frankly, it takes a personal toll on me and the people that I work with, but I feel like I have a unique opportunity to advocate for consumers to attack the affordability crisis. That's not easy, and when you talk about disruption, you can really get into some prickly areas. But I do love the opportunity of trying to negotiate, find creative solutions, partner with whether it's a hospital systems, physicians, pharmaceutical, and opportunities to increase access to higher quality and lower cost care. It is a really unique opportunity. that we have as insurers. Sometimes that's done very adversarially and poorly by insurers, which we all see the headlines. And I'm not advocating for that. But I don't know that the average person realizes how personally and seriously I take, and the teams that I take, in actually advocating on your behalf when you're trying to purchase healthcare, right?
Do you have an example that you can share?
Yeah, I think that, and we'll probably get to it, but on the pharmaceutical side, right? So we are, I think we all know there is a cost crisis when it comes to pharmaceuticals. And so we are constantly pursuing different ways to make sure, one, that there's the adequate supply of pharmaceuticals, but also, can we do different creative things to lower the cost, right? I'm at Blue Cross of Idaho, and me personally, I'm involved. I'm on the board of Civic RX, and the mission of Civic RX is to go and try to find areas where we can, one, where there's shortages in manufacturing of critical drugs, but also where can you manufacture drugs and offer them at a lower price to consumers. Civica's insulin initiative is probably one of the most prolific and well-known initiatives, and insulin's a great example. The cost needed to go down. It needs to be more affordable. And I think when you sign up for that, though, you're signing up for a little bit of a fight, right? There's some groups that maybe don't like that, and I think you're signing up for a fight. I think, with hospital systems would probably be the biggest example, and we see so many payer hospital wars in the media, which does no one no good. But it is an opportunity for a payer to work with hospital systems and take a look at their costs and their expenses and how that actually impacts members and patients, right? Depending on the insurance plan, the costs are just extravagant. And so that would be another opportunity. Now you have to do that. And that's the great thing about being with Blue Cross of Idaho is we live in these communities. So this is not a hospital system that is 3 time zones away that the insurer can just go to war with, right? We have to work with these partners. And so how do we work with them in showing them the cost impacts and the impacts that are having on the community, but at the same time valuing and showing how important the services that hospital provides to the community as well. But those are tough conversations. They're challenging conversations. But I also see that as an opportunity for me to help serve the communities and the people that we have in this state.
And oftentimes when, the payers have certain obligation that they need to meet, and the provider, the health system have their own as well, how do you find the commonality? It's just like any other business relationship. And how do you're mentioning that they're not 3 states away, they're a close part of your community, that makes the building that relationship accepted, and they understand the need to work together. How do you start a conversation? Like, do you have like a case study, the success stories that you can share?
So one of the opportunities, I think, from a payer standpoint, is actually one of our opportunities is to show our operational partnership. Are we denying authorizations left and right and creating huge administrative burden for that hospital system or that provider group, right? If you're doing that, it's really hard to have earned the right to talk to a hospital system or a provider group, whoever it would be. You have to be a really good operational partner. And we try to do that as best we can within Blue Cross of Idaho. Do we make mistakes? Absolutely. But at the end of the day, the hospital systems and the providers here know that they can pick up the phone and they can talk to people and interact with them. So it starts with that. I think that, what we really try to do is try to find a middle ground of where we can both appreciate what we're trying to do to serve the populations and at the same time try to help control costs. So an area on the provider side, we are constantly dealing with in the state of Idaho that we have very low primary care per capita percentages, very low psychiatrist per capita percentages. Continue to go down the list. We really struggle. So we're always looking for opportunities to provide financial support, frankly, to bring in more OBGYNs or primary care physicians, behavioral health specialists. And I think that gives us a lot of credibility when we show our ability to put money forward in increasing that. The other one would be what is value-based care, right? So if you're a hospital system and your cost per musculoskeletal procedure is 2x what the other options are, around who they're competing with, we try to show them that. But then we also try to show them how that impacts their value-based care arrangements. If you have a value-based care arrangement, those hospital systems and the clinically integrated networks are financially incentivized to deliver high quality, low cost care, right? So if you have a value-based care arrangement, which we believe strongly in, and then you're also charging 2x of what you could be for a knee replacement, that's actually negatively impacting your value-based care arrangement. And you have to provide financial opportunity on that value-based care arrangement. So that's where we try to find the sweet spot. We do provide data. We try to be as transparent as possible to show where there are market discrepancies in cost and quality.
And you mentioned about the value-based care. If their cost is 2x from what's out there, how is that impacting negatively to this provider? Because oftentimes when I think about many of the provider, the fee-for-service one is the more you deliver the service, the higher the cost, the more.
Yeah, I think one, just from a pure mathematics on a value-based care arrangement, and a value-based care arrangement is based on there's a quality and financial target. And if the clinically integrated network, the provider system operates within that and below a target, they actually get to share in the savings, right? So if I am charging extremely high on lab, imaging, cardiovascular, musculoskeletal, pharmaceutical drugs, et cetera, it's going to be really hard for me as that clinically integrated network to hit those value-based opportunities. So that's where it's, the old as a hospital or provider in a fee-for-service, I'm incentivized to deliver more care at a higher price. If you have value-based care arrangements, it's actually the opposite. They're actually incentivized to proactively manage care. So going back to that diabetes example that I gave, that hospital system and the provider system is also financially incentivized to hit that or thread that needle that I was talking about, where it's better member care, it's better member outcomes, right? So they are helping make sure that Mrs. Jones is getting into the doctor as much as possible, because that's better for her quality of life, better for her managing, but it also is an avoidable ER visit at that point as well, right? And so that's where we really try to land.
You mentioned earlier about in Boise, in Idaho, the shortage of primary care and a psychiatrist. What can a health plan like you work with the provider to improve that condition?
Yeah, absolutely. So within Blue Cross of Idaho, we actually, one of our 5 strategic goals is improve the health of our communities. And we say that and we articulate in those words because we also are willing to go outside of whether or not they're our member, right? So there are communities that do not have enough behavioral health services physicians, primary care physicians, OBGYN, you name it. And so what we do, one of the things that we do is we actually try to provide capital to different groups who are trying to expand primary care physicians, behavioral health physicians, everything that I just went through. So we're willing to do that. What we don't do, what we haven't done is what you see nationally, where you see a lot of insurers buying or being the sole employer of those providers, where we will provide capital and that could be maybe in a small equity kind of investment. The other one would be sometimes it's just in-kind donations and contributions, right, to help increase those number of providers. We believe that we as an insurer could get in the way of care if we are controlling physician practices. So far, we've taken minority investments to try to expand capacity. That's been one of our biggest. The other things we try to do is we will partner with some of the local medical schools, medical programs, residency programs, and where we can chip in, frankly, to help improve access to care. That's what we do.
Does that mean by having the students taking more students?
That is one of the things that we've done is we've partnered with one of the schools in trying to actually look at innovative programs to encourage more residents and medical students to stay in Idaho and actually serve in a rural capacity. So that could look at like student loan forgiveness, things like that. That's probably one of the areas that we've really tried to engage in. Another thing that we do is, and it's through our foundation, is actually there is a Project Echo is a national program. I believe it started at University of New Mexico. At the University of Idaho in Moscow, Idaho, they've got a Project Echo venture. And part of that is trying to provide training to rural physicians on the behavioral health side. So I may be the only primary care physician in a small town in Idaho. I end up being the receiving point for all kinds of different conditions. So through Project Echo, trying to provide training, coaching, collaboration groups on being able to handle those. And I think that is a really good model. I really like the Project Echo model.
You mentioned earlier about Civica RX. And I think, tell us more about how the genesis of it and how did it all come about and what the impact has it done so far and what is Envision trying to do?
Yeah. So like I was saying before, Civica RX really was the brainchild of Dan Lillenquist, who is the chief strategy officer at Intermountain, and Dr. Harrison, who is the former CEO. They got together with a large number of hospitals across the country and said, we really need to take a look at some of the pharmaceutical manufacturing supply. One is stability of supply. And I think we all saw in 23, right? We saw the headlines of cancer drugs not being available, different behavioral health medications not being available. So how do we go after and look at the manufacturing supply to provide stability, and then how do we also look at some of the prices, especially on some of these generic injectable medications? So, that was probably 5 years ago, 2019, 2018, and Civica was formed. And they have an unbelievably impressive grouping of the largest hospital systems across the country. What they've also created is something called Civica Script. And then that's where they then reached out to payers and said, well, would payers have interest in this as well? So being able to access lower cost generic opportunity medications. And then finally, through the Civica Foundation and different fundraising efforts, really looked at insulin and said, gosh, insulin is over 100 years old. The prices are astronomical. Can we bring to market a vial of insulin that is at a very manageable cost? And so that's the background of Civica. I personally, Blue Cross of Idaho got involved, going back to 2019. We started talking to the folks at Civica about possibilities on distribution. And they were talking about, would there be a payer distribution opportunity, et cetera. We shared that we are very interested in opportunities to provide access to lower cost, high quality medications. And so with that, I got the unique opportunity to be on the board of Civica RX. It's been really interesting. Civica RX, I think it's 30, 40 medications that they are purchasing, manufacturing, and delivering into the market. Civica has opened its own manufacturing facility in Virginia, and then they're working passionately on manufacturing and getting insulin into the market. So it's been really great.
How is it, I'm just trying to understand, many of them are generic, but how come the cost was still high? I mean, I know in the state of California, I think that was a couple of years ago, they're saying that we're going to manufacture our own. What caused the price to stay high when it's generic?
Yeah, I think in a lot of the areas that Civica has gone after, it's been the shortage of manufacturing supply. So some of these generic drugs are very difficult for the manufacturing groups to make profit on. And so I think that a lot of times you have a manufacturing supply issue. And so that's what Civica has gone after that.
Okay. And one of the things that maybe you can share with our listeners, you're the chief revenue officer. What does the chief revenue officer?
That is a really great question. I have failed in being able to describe that to my children and my wife. And so here we go. And maybe I could take a step back and I could just talk about my history here at Blue Cross of Idaho. I think I was sharing at the beginning about how moving from a publicly traded national plan and the interesting components of moving to a single state nonprofit health plan. What has been really fun is I've been given the opportunity within Blue Cross of Idaho to expand out of maybe necessarily my background and to be responsible for other areas. And so since I've been at Blue Cross of Idaho, I came here to help Blue Cross of Idaho move to value-based care contracting. And so it was We were negotiating with hospitals and providers, but we really wanted to go deep into value-based care. And so that's how I started. I then got so many opportunities to oversee other areas. I've been able to oversee healthcare operations, our healthcare economics and analytics shop, our pharmacy organization, our IT organization, our product and P&L organization, our strategy in corporate development organizations as well. And so I think it's been a really unique opportunity to be able to see all the different components of the health insurance model. So within that, I do have a pretty broad portfolio of things that I'm responsible for. I think that ultimately what we're trying to do is we're trying to increase access to low cost, high quality care. And so from a chief revenue standpoint, many days what that looks like is I'm overseeing our teams who negotiate with hospitals and providers and are looking at network adequacy and access. I oversee our product and P&L team. So what types of insurance products are we taking to market and what are we doing from a cost standpoint, right? We really want to be able to drive the cost down of health insurance products. That has been much more difficult than I ever could have imagined. And when we made bold statements like we wanted to reduce the cost of care, reduce insurance products, it's always been amazing to me how many people tell you can't do that. I oversee our corporate strategy group. And so we're constantly looking at opportunities like we talked about. Do we need to help bring in more physicians? Do we need to expand our products and our services that we offer? And so from that standpoint, that's what I'm doing from a chief revenue standpoint is because we're not profit, we're held to a very, very razor thin net income margin. What we want to do is we want to be able to provide sustainable insurance products in this market that help people get access to care.
And you're also the chief of innovation. What does an innovation look like in your organization?
So one of the areas is I would say that if you're going to address the affordability crisis, you've got to be innovative. You have to be willing to disrupt. I actually will use innovation and disruption synonymously when it comes to healthcare. That's when you're looking at opportunities to potentially do things different from care delivery, cost, et cetera. One of the examples would be our former CEO, Charlene Marr, about 4 or 5 years ago. She said, we as insurers, we just keep rearranging the deck chairs, looking at the same things over and over and over. There is an affordability crisis, and I'm not seeing anyone do anything different. And so we started this conversation. We talked about a few things. One, we said, well, we're sitting on piles of data. We have a lot of data that shows us what is happening with our members, where care is being delivered, what the costs are, et cetera. We then took a look at how could we look at the science of what we do from a data standpoint. The other thing you had going on is you had an onslaught of different groups bringing solutions, especially to large self-funded employers, and saying, buy this solution. This solution is going to help you. And you had these large employers saying, all I know is my costs of healthcare are going up 10% a year, and I have no clue where to go or what to do. And so we created a healthcare economics division. We now call it Ruby. And the intention of that was to, one, take the data and look at it and look for opportunities. So instead of looking at data in kind of an old-fashioned way of inpatient, outpatient, ER, it doesn't really tell you where your opportunities are. So we said, how can we evaluate that data and go look at it differently to see where the costs are? And so what we did is we decided we were going to look at the data in an episodic fashion. And what I mean by that is instead of saying how many people were in the hospital, it's more of a, what are your leading costs by condition? Musculoskeletal, cardiovascular, cancer, rare genetic disease, diabetes. Those are your conditions that a self-funded employer, Medicare, Medicaid, government employer, that's where they're spending the most of their money, right? From a cost standpoint. And we said, so that's where the money's going. Can we do problem statements? Can we figure out what's driving that? And where are opportunities to implement solutions to go and address the cost within those conditions? And so that's an example of what we did from an innovation standpoint. That's been wildly successful here within Blue Cross. Within our ability to take that to our self-funded employers, we actually have another health plan that is buying that service from us as well, which is part of my responsibility, chief innovation, chief revenue. And so that to me is an example of innovation. That's where you have to be able to look at the way you've been doing things, where that old way is potentially archaic, and look at a different way of delivering.
So do you do your innovation in-house, or how do you incorporate people from the outside?
Yeah. When it comes to the initial part, which is evaluating the data, doing the analytics, and then designing solutions, that's 100% in-house. Now, when it gets to the solution, that can be a combination of different programs, some internal and some external, depending on what we're going after.
Mm-hmm. And what is the pro and con from doing the in-house and the outside?
Well, one, we're extremely lucky. So we're extremely lucky because what we discovered was we had a large number of actuaries, as most insurance companies do. We had a large number of actuaries and really just brilliant mathematical analytic folks. What we also had was we had quite a few of them were looking at opportunities from a mission standpoint to make healthcare better. There's a lot of great components of actuary. A lot of what they end up doing is really doing kind of product design, product pricing. And we had a large group of people who wanted to go make healthcare better. And so we were lucky from that standpoint. So from a con standpoint or difficulty, if you're a health plan trying to do this, is do you have the talent in-house, and do they have I would say it's not just the talent to do the analytics, but they've got to have the mission, an altruistic mission to serve people and make healthcare more affordable. So that is the really challenging part. We were lucky we had that. We were then lucky as we grew that team and we were recruiting, we found places and people that were attracted by that same mission. So I would say that's probably the hardest part. The pro is reorganizing your data internally and providing transparency into that data changed our company culturally. There's so many things within insurers that you have walking around, quote unquote, knowledge. And when you pull the data and you do the analytics, you actually see where you were actually wrong. And the opportunities to improve healthcare is different than what you thought. And so when we first started publishing the data and the analytics we were doing, it was amazing to me how many people said this can't be right. That can't be possible. I've always thought of cost for 20 years within one way, and we showed them something different. That being said, over time, people really come to value it. And so that would be the pro, is how it's really transformed where we deliver. I think going back to your innovation question, we made a commitment that we were going to be willing to try things. But if we were willing to try things, we had to thoughtfully design them based on the data, but then we also had to measure them. So I'm perfectly happy to try something and find out that it works or doesn't work. That's perfectly fine with me. What I can't stand, and I think healthcare does a really good job of, is we all implement these solutions and sell these solutions, and no one has any clue if it worked or not, both from a cost and from a quality outcome standpoint. It can be very challenging. And so we were going to be committed to implementing and trying things, but we were going to be committed to measuring them. And if they weren't working, that's fine. That's a fine outcome. And let's make a decision of, do we need to change it? Do we need to continue and put more gasoline into that engine? Or do we need to frankly kill it, stop doing it? There were existing programs that we had that, when we measured them, it was amazing to me about how some of these quote unquote healthcare solutions were actually driving bad behavior and creating more cost, right? But that's a cultural change, which was very beneficial to us at Blue Cross of Idaho. And I think it made us a lot stronger and better. So, on your pro and con question, I would say it's difficult. It's difficult to have the talent. You also have to be really willing to understand the data and not rationalize it away. Healthcare is really good at rationalizing away data. But then you also have to be willing to make decisions based on it. And that's been really good for us culturally.
Oh, that's great. Well, last question. What advice do you have for innovators who are interested in working with Blue Cross of Idaho?
For innovators, just in general, I would say mission first, not financial first. Find the sweet spot where you can thread both those needles like I was talking about, but start with mission first. If you start with mission first and you're trying to figure out how to deliver healthcare differently, and you go and you look at the problem statements and the root causes, and you are transparent and willing to admit where even maybe you personally, there's a lot of times as an insurer, I have to say, man, we're really making this worse. We've got to change. And so I would start with mission first. Make things better, deliver healthcare differently and better. That would be my first thing. And then figure out the financial model, like I said, that works and threads the needle. I think from an insurance standpoint, what is really difficult is the number of point solutions. There's so many people that are out there and they have great programs and they have great ideas. There's a thing that we talk about in health insurance, and you can hear large employers talk about it, is point solution fatigue. I want to address the overall cardiovascular issue within our population. How do I help address that? If someone brings a single kind of single small component of the overall cardiovascular opportunity, it's less attractive to me than if someone brings a more holistic cardiovascular solution opportunity. And so I know within the Rosenman Institute, you guys work with so many awesome innovators. I would encourage them to think that through. Think through if you're going to an insurance company or a large healthcare system and you're trying to get them to engage in your product that you really believe in, think through the ideas of point solution fatigue. Think through how you could partner or bring in more of a comprehensive, widespread solution. I think that's something that's going to make things more palatable. A lot of the folks are sitting there saying, this is a great idea. I just don't know how I'm going to implement it.
Mm-hmm, mm-hmm. It's almost that oftentimes the startup needs to team up with another startup and then form a coalition.
Potentially. I think that's right. I would be very intrigued by that. Yep.
Yeah. Absolutely. Well, thank you, Drew, for sharing your story and your insights. Really helpful. And I learned a lot from you today.
Thank you so much, Christine. It's great talking to you.
Thank you for tuning into today's episode of the Health Technology Podcast. We hope you found the conversation insightful and inspiring. If you enjoyed this episode, please take a moment to subscribe, rate, and leave a review on your favorite podcast platform. Your feedback helps us continue bringing you the latest in health innovation. Stay connected with us on LinkedIn and Twitter for updates on upcoming episodes and more. Until next time, keep pushing the boundaries of what's possible in healthcare. I'm Christine Minato, and thank you for listening.